Ta-da! Is it Thursday? My goodness, this week has flown by, but we are here with so many amazing people. This has been a waited part two. People have been asking us to have Dr. Simmons and Nicole back, and here we are. I'm going to introduce them. I know there's still some people walking into our Zoom room. So Dr. Simmons is triple board certified by the American Board of Clinical Neurophysiology, American Board of Psychiatry and Neurology, and American Board of Sleep Medicine. He is the founding director of Comprehensive Sleep Medicine Associates, located in Texas, with offices in Houston and Austin, and also providing telemedicine services for patients out of state. He also is the founding director of the Sleep Education Consortium that provides education to healthcare providers. He's involved with many research activities and sits on the board of other sleep-related organizations. Nicole founded the San Diego Center for Speech Therapy and Myofunctional Therapy in 2003. She is one of the only 3 speech-language pathologists in San Diego County who holds a joint certification as a certified orofacial myologist through the IAOM. I know that I cut a lot of stuff off because it would be, 30 minutes because you guys are just so accomplished for me to say everything. So if you will, please say hello to everybody and compliment in the introduction. Dr. Simmons.
Well, thank you. It's a pleasure to be here. My phone seems to be going nuts, so I'm turning it off. There we go. Or at least one of my phones. Okay, well, it's a pleasure to be here. But before we get started, let me just, you mentioned the various organizations that I either started or part of, but the Sleep Education Consortium, we've been doing conferences for like over an 18-year period. We've done 16 conferences, and we've got one coming up. Can you see the screen?
Yes.
Okay, so we have a conference coming up in February 3rd, 4th, and 5th. It's going to be our Sleep Education Consortium conference. It's going to be real comprehensive on sleep disorders. So I just want to let people know about it. And there'll clearly be a useful information for myofunctional therapists. Actually, Joy Moeller is going to be there presenting. And we're going to have a lot of Kevin Boyd is going to be presenting, and there's a lot of cutting edge information that will be there presented at the conference. A lot about aligner therapy and the use of aligners in conjunction with oral appliances, and just a lot of things. So anyhow, I just want to get the heads up. The webpage is dentalsleepconference.com. Register. We have a discount going now that will last a little bit longer for people that register. And anyhow, it's a 3-day conference with a lot of useful information. So
that is an insane lineup. I feel every time I go to a new conference, Dr. Boyd's like, "You're here again." Like, which I'm sorry, these people are just so amazing. I don't want to stop going to them. And Nicole, if you can please say hi to everybody and tell us what you've been doing.
Yeah, thanks so much for having me back. I'm so excited because I think we have a great list of questions to kind of get Dr. Simmons to answer so many questions. Any conversation with Dr. Simmons, I'm like a sponge. I'm like, tell me everything. It's all this amazing sleep information. So I'm excited to be back. And again, if I have a slight slur or lisp, I have my MSc in still with about 10 rubber bands pulling my teeth in some direction. So hence the diastemas and the lisp.
Well, I love it. And we have Dr. Bill Harrell over here. You want to say hi, Dr. Harrell?
Well, hello everyone. Hey, this is great. When I saw Nicole and Jerry on, I said, and with Renata putting this together, this is great. Glad to be here. Thanks.
Thank you for being here. So our topic tonight, again, airway, sleep, and beyond. Part 2. If you guys have missed part 1, it is on YouTube. But most of these now will be saved for members only. So if you're not a member of Airway Circle yet, please join us. It's only $25 a month, and we have tons of videos and resources and things for you guys to go back to and listen. So I will start with our first question. And are night terrors related to sleep disorder breathing? What about sleepwalking and sleep talking? Throughout the conversation, if you guys have any questions, please just post it on the chat or on the Facebook messages, and we'll bring them over to you guys. But
so, okay, the question is, are night terrors related to sleep disordered breathing? Okay, so they can be in many patients. So night terrors can occur for a variety of reasons. It could be part of a post-traumatic stress disorder. They could be for related to stressful scenarios. The thing about it is that patients that are going to have something that will disturb their sleep, the person may not fully awaken, and they may go off into having what we call a parasomnia. And sleep disordered breathing can be something that's going to cause this disturbance. So we'll find that patients that are having night terrors are going to have other things that can disturb sleep. Could actually even be periodic leg movements of sleep. So it doesn't have to be specific to obstructive breathing, but obstructive breathing is a common phenomena. So there are a lot of patients that will have obstructive breathing as a triggering factor. But what's really interesting is a related condition, post-traumatic stress disorder. Okay, so we talked about how patients with post-traumatic stress disorder might have night terrors. There have been studies that have shown that there's a real high occurrence of sleep apnea in patients that have post-traumatic stress disorder. So why is that? Is it that the post-traumatic stress disorder is causing the sleep apnea, or does sleep apnea create a scenario that makes a higher likelihood of someone developing post-traumatic stress disorder when being exposed to a traumatic event? And that's probably more of the scenario, that if someone is going, if you take two individuals and they're both presented to the same stressful event, one person may sleep just fine. And sleep is necessary to resolve the issues associated with the stress exposure. So if you have someone that isn't getting normal sleep because of, let's say, sleep apnea, they're not going to get the proper resolution of the stress exposure, and then that individual is more likely to evolve on to developing post-traumatic stress disorder. So there is an association between obstructive breathing, post-traumatic stress disorder, and post-traumatic stress disorder is associated with night terrors. So maybe hopefully I answered your question.
yeah,
just a quick question for PTSD. Is it somewhere I read it's like 80% of people with PTSD have sleep apnea, or a number?
Yes, that's a statistic that's been found before. And there have been a number of studies, and some of them are quite as high as 80. Some of them are going to be, maybe 60% or so, but it's a high percentage. I believe it's going to be and the reason why there may be a lot of variation could also relate to how do people identify sleep apnea, which might be something else that's going to come up during our talk, because not everyone defines obstructive sleep apnea the same way.
Okay, should I ask the next question, Renata?
Go ahead.
What about the relationship between acid reflux and sleep disordered breathing? Explain that.
All right. So when we're talking about the physiology of sleep disordered breathing, well, sleep disordered breathing is a larger category. So let's talk about obstructive breathing during sleep, okay, which is a subtype of sleep disordered breathing. It would be obstructive breathing during sleep. So what is obstructed breathing during sleep? So when a person's breathing and air rushes through the back of the throat, there will be a negative pressure or a vacuum that's going to be developing in the back of the airway. And as the airway becomes more narrow, then you're trying to get the same amount of air through a smaller space. So there's a stronger vacuum that gets created. So the degree of negative pressure is going to be associated with the amount of air you're trying to get into your lungs and how much space is there to get that air into your lungs. So there's a stronger degree of a vacuum or negative pressure that gets created with the higher degrees of obstruction. But the thing is that negative pressure is not just in the back of the airway. It gets disseminated into the whole chest cavity. So your whole chest becomes like a vacuum chamber with a big negative pressure that is going to occur in patients with a high degree of obstructive breathing during sleep. So if someone has a incompetent lower esophageal sphincter, so the lower part sphincter at the bottom of the esophagus may not be as tightly constricted, gastric fluids can be sucked up from your stomach up into the esophagus by the increased obstructive breathing. So when you have this big negative pressure in your chest, this fluids get sucked up and then you can get more reflux. So we found years ago that if we were to titrate CPAP in patients that also had nocturnal GERD, and we did that with the patient having the nasoesophageal pressure manometry while we're doing the titration study, if we increase the CPAP, not just to the level that stopped the obstructive sleep apnea, but we continued to increase the pressure until we normalized the interthoracic pressures, those patients had improvement or resolution of their nocturnal GERD symptoms. So we were treating it without any kind of antacids or proton pump inhibitor medications. So it's not to say that all GERD is related to sleep apnea, but sleep apnea will make GERD worse.
The next question is a very interesting question, and I'm going to try to marry to the first question that we had. Should you be remembering your dreams? But I would like you, if you can touch a little bit, we talked about night terrors, and now we're talking about dreams. Would you talk a little bit about the stages when the night terrors, in which stage does night terrors happen, and which stage does regular good, I guess, dreams are supposed to happen?
Okay, so a night terror is typically going to occur in slow wave sleep. In non-REM sleep, typically slow wave sleep. It does not occur in REM sleep. In REM sleep, your body's supposed to be paralyzed. And so someone could have a nightmare, which is a really bad dream, but they're not moving. They're not actually acting out their dream activity. So the part of the brain that causes this muscle paralysis that's part of REM sleep, if it's not functioning correctly, then the person will start acting out their dreams. And that will be something that we refer to as REM behavior disorder. And that's a whole topic in and of itself. It could be the earliest manifestation of a degenerative condition within the central nervous system, such as Parkinson's disease. We know that patients with many patients with Parkinson's disease actually will present with REM behavior disorder many years before they start having the other symptoms of Parkinson's. So it may be a red flag for an ongoing degenerative condition. And if that's the case, then if we're thinking about putting someone on medication that may theoretically decrease the progression, which right now we really don't know what medicines would really decrease the progression, but if we identified certain medicines that were clearly decreasing the progression, it would be really wise to give that at the earliest stages of the condition. And the earliest stages of the condition may be when something like REM behavior disorder first presents itself. So I know that's a little bit off from what your topic is, but you're talking about distinction between REM and different stages of sleep and having night terrors. So night terror is going to also involve movement. Someone's doing something in their sleep, usually they're yelling, screaming, frantic, high sympathetic activity occurring, and it's during slow wave sleep. And during slow wave sleep, there's a very um, uh, high arousal threshold, meaning the brain is trying to stay asleep and it doesn't want to wake up when exposed to circumstances that would otherwise cause awakenings. So if you were, let's say, in stage 1 sleep and you had something happen, you'll wake up. But if you're in slow wave sleep, that same thing may occur. There may be some environmental disturbance, okay, some noise in the environment. In stage 1, it might wake you up. In stage 3, slow wave sleep, it wouldn't wake you up. But it may cause you to be disturbed to where you're going to be in this quasi state where you're not awake, but you start doing automatic behaviors. And you may start doing things in your sleep without fully awakening. And that would be a non-REM parasomnia. And when that's associated with very frightening types of emotional activity, then that would be a night terror. So did I answer the question?
Yes, you did. And how about people remembering their dreams?
Okay, so there's different responses to dream sleep, REM sleep, in that for some people it may be natural to remember their dreams, and other people, most people, don't remember their dreams. What's real common is that when you wake up, you may remember your dream right when you wake up, and oddly, you can't remember it 3 or 4 hours later unless you actually do something to solidify the memory. It's normal for your brain to extinguish the recall of what occurs during your sleep. Now, is that part of a self-preservation phenomena? Because maybe we're not supposed to remember our dreams? I don't want to go to that extent. I don't think that's true. But there are other people that will remember their dreams in detail every single night. Right? Okay. Well, but that's the way you are. So what's, to me as a clinician, what's more important is if there's a change. So if you tell me that you've been remembering your dreams all your life and that's the way you are, okay. Now, if you said, but Dr. Simmons, in the last 3 months, I can't remember my dreams any longer, that change could be significant. And the vice versa may happen, where people say, I never remembered my dreams, but all of a sudden now I'm remembering them all the time. So it's the change that is significant, and there's a variety of factors that can be associated with that. But I think that's what's more important. So someone shouldn't feel bad if they can't remember their dreams. When someone tells you that they don't dream, that's just not true. They may not dream as much. They may have a little bit of, a decreased amount of REM sleep. But the scenario when someone says they never dream, it's just that they don't remember their dreams.
Mm-hmm. With regard to the parasomnias, what about sleepwalking or sleep talking? At what ages would that be considered normal or a sign of maybe an airway disorder?
Well, it's considered normal for a growing child to have a sleepwalking event every now and then. So what's every now and then? So, the world is not black and white. It's various shades of gray. But as a basic recommendation is if someone has had, let's say, one sleepwalking event every 6 months over, let's say, a 2-year period, but it's not really any more frequent than once every 6 months, and it's only been going on for like 2 years, I would just continue watching it, and it'd probably go away in most cases. Right. So if a child has a sleepwalking event, that doesn't justify a whole thorough evaluation. But let's say it's about once a month and it's been going on for, let's say, 9 months now, that would be considered abnormal. Okay. So if it's sort of a rule of thumb that if the abnormality persists for more than 6 months, it's worthy of evaluation. And if the frequency, it could still be, twice a month for 3 months. You could maybe at that point ask the doctor about it to try to, and get an evaluation, but it's still maybe premature at that point. But what I would clearly recommend is that the parent look for other factors and make better observations. So breathing abnormalities would be a common cause for a parasomnia, for triggering the awakening, but the child doesn't fully awaken, and then they carry out some behavior. They're going to get up and go, and uh, they're going to, let's say, urinate in the other room, which is not a bathroom, and they're not going to know what they're doing it. And they're going to have to sleep with doing it. So, does the child snore? Is the child a mouth breather? Or are they drooling on their pillow? Or do they kick in their sleep? Are they hard to fall asleep at the beginning of the night? Or are they hard to wake up in the morning? Are there other things that are going on? Does a child have ADHD kind of behaviors? Things to suggest maybe the child's not getting good rest. So if there are these other factors going on, as let's say a baseline, and then you start having the parasomnias, I would say that those other factors already warrant an evaluation. And the fact that the parasomnias are now occurring enhances the significance of these other things that have been going on that the parent isn't sure. So in other words, I wouldn't wait 6 months if all of a sudden the child that's snoring and has a hard time waking up in the morning and now they start having parasomnias. I would do the evaluation after just 1 or 2 of these parasomnic events. I'd do them even without the parasomnic events, is really what I'm saying. So, but if a child is otherwise normal and they have a parasomnic event, I wouldn't rush off to the doctor if they're few and far between.
And including sleep talking, similar concept.
Okay, so, yes. So sleep talking, yeah, and again, I'd look to see what constitutes sleep talking. Is it just a little mumbling at one time during the night, and the rest of the night the child's fine? Versus they seem to be doing it quite frequently, and they're tossing and turning, and there's other factors going on. Then those are signs of disruption.
I see part coming.
I know.
Started getting questions now. There's some good questions on here. Since there's a couple questions on dreaming, I'm just going to go ahead and ask them so we stay in topics over here. Nima Hernandez asked, what is lucid dreaming and is it relevant?
Well, is it relevant in terms of a sleep disorder? Well, no. There have been people that train themselves to do lucid dreaming. There's, I guess you may call it the art of lucid dreaming. So what is lucid dreaming? It's when someone's in a dream and they become aware that they're dreaming while they're dreaming, and then there's all these things that they could do knowing that they're dreaming. Well, how can that happen? Well, so Dr. LaBerge, I think is his name. He was at Stanford University years ago. Was very into this. You have to have some kind of stimulus to know that you're actually dreaming. So he actually devised some kind of goggles that it had like these little piezo electric sensors that would go over the eye, and whenever it noticed that the eyes are moving, it would say, okay, you're in REM sleep. And then there were these little LED lights that would start to flash. So then you sort of tell yourself, while I'm asleep, if I see these flashing lights, I'll know that I'm in my dream. And then I'll know to tell myself this is all a dream. And so if you sort of prepare and you rehearse and you do it, eventually you get to the point where you could do this. I've never practiced this, this method, and nor do I recommend it, and I don't use it for any therapeutic benefit. But there are some people that make claims how this can be used therapeutically, and so that's what I can tell you about lucid dreaming.
More. It's funny. I dream a lot, almost every single night, and I remember.
But are you aware? Do you tell yourself that you're dreaming when you're dreaming?
Yes, many times I can tell. Yes, and I can make things do what I want to do.
Okay.
Dreaming. Let me have fun.
No, it's great.
Nicole, can you see the chat? Do you see Ryan's
Yes.
question?
Which question?
Ryan.
Yes. Okay. So this question by Ryan Alkalkar says, are there treatments beyond airway adjustments, such as CPAP, for people who dream so vividly nightly that they never feel rested? Any other type of assessment recommended?
Well, okay, so I'm trying to really repackage this. Okay, so you're talking about dreaming and feeling unrested. So one of the scenarios that can occur is if someone's REM sleep is fragmented due to repetitive arousals, then there may be recollection of what's going on during the dream because they keep on sort of coming out of it, and then they go right back into the dream and they keep on coming out of it. But what's pulling them out of it could be obstructive breathing. So obstructive breathing, so that would be, let's say, a scenario where someone didn't remember the dreams, and now all of a sudden they start remembering their dreams. And especially if they tell you that I'm dreaming about not breathing, I'm choking, or I'm struggling, and there's a common theme. And I've had patients that have told me this before. Then there's a high likelihood that it's probably obstructive breathing that's occurring. And it's going to be worse during REM sleep, during that muscle paralysis that I was talking about earlier, that occurs during REM sleep. Well, that muscle paralysis affects the upper airway muscles as well. So the upper airway is more vulnerable to collapse during REM sleep. So someone may start, having these increased dream events, and they're feeling unrested. So the fact that they feel unrested is not because of the dreams. I think the fact that they're remembering these dreams all of a sudden is because of the same thing that's causing them to feel unrested, and obstructive breathing would be the most common cause. So in terms of what kind of assessments, well, a polysomnogram would be the best way to do this, having someone come into the sleep lab. One of the problems with a lot of these other technologies that people are using for evaluating sleep is when the sleep gets very fragmented, they become less reliable in identifying which stage of sleep someone may be in. But if it's a breathing problem, it still may recognize that the person is having a breathing problem. It just may not recognize the correct stage in which that occurs.
What about there's a question from Andy, and it's kind of another possible, I guess, would you consider bedwetting a parasomnia? Enuresis of parasomnia. But the question is, it sounds like at age 6 or 7, would that be related to sleep disordered breathing, or what age would you consider it normal for a child to either get up to urinate or wet their bed at night? And what age would that be a concern?
Well, it's variable. Clearly, let's go with extremes because it's not like a fine line. It's not like, you're less than 3, so it's okay. But now, you just had your 3rd birthday, so now it's not okay. I mean, you want to look at frequency over time. So the frequency should decrease over time. But clearly, when the child is 6 or 7 years old, and they're continuing to have bedwetting, or 10 years old, that's not normal. And we know that obstructive breathing is one of the factors that can be leading to this phenomenon. The question is, how can obstructive breathing result in bedwetting? Well, there's 2 principles that to think of here. One is that in really bad obstructive breathing, there is an increased amount of urine production that's occurring. And that's because of increased atrial natriuretic peptide that's released from the heart because of the changes in the blood flow dynamics that occur from the obstructive breathing. And I don't want to, it takes a little time to explain all that, but that's going to be in more extreme degrees of obstructive breathing. In milder forms of obstructive breathing, we could still see bedwetting. So one of the things is that if you're having repetitive arousals, or let's back up, if you're having repetitive events that can potentially precipitate arousals, your brain tries to suppress these events, or they're trying to suppress the arousability so that you are not as likely to be disturbed by these events. All right. And so it tries to filter them out. So if you have obstructive breathing, the brain is trying to stay asleep in the setting of obstructive breathing. And so it's working hard to drown out these sensory stimuli. So in the setting of all that, if all of a sudden the bladder gets distended, but the brain's trying to stay asleep, it will drown out the sensation that the extended bladder may be producing. And so the child will then not wake up from the distended bladder and then go to urinate. So once you've treated the obstructive breathing, for one, the child may not be sleep deprived. So that's going to then lower their arousal threshold. And the brain's not being desensitized to this ongoing stimuli. So it's going to arouse more from the distended bladder. The distended bladder is more likely to cause an awakening once you've removed the obstructive breathing, if that makes sense.
Definitely. I don't know if I should go into our questions or these new questions that we have. I know
that is interesting. The follow-up from Ryan about the vivid dreams, and if it's not resolved, do you want to read that one?
The one that says, "Thanks for answering."
Yeah.
What if the intense vivid dreams aren't resolved with a CPAP? Do we now think of this as a psychological condition not related to obstructive breathing?
So let's talk about it not being resolved with CPAP. There's more than one way of administering CPAP. It's not CPAP yes or no. It's is the CPAP being administered optimally? And I bring that up because nowadays a lot of times people are just being put on a machine and they're saying, let the machine figure out the right pressure. And the machine may not be coming up with the right pressure, and the person may still be having respiratory events. But then they could say, well, the machine says I'm not having respiratory events. I've seen instances where the machine just doesn't get it right. So the respiratory events could be more subtle. They could be effort-related, they could be effort-related arousals and not full-blown sleep apneic events. And so still there's the disruption that can occur. So again, the best thing to do is to go into a laboratory that is going to look meticulously at these parameters during the night and see if the pressures have been set correctly. And then the question is, the night that you go into the sleep lab, are the same events actually occurring with all the vivid dreams and waking up feeling unrested? Now, narcolepsy is a common condition that gets missed. And narcoleptic patients can have very fragmented sleep. And they're going to continue, and a narcoleptic patient may have sleep apnea. And so when we find sleep apnea, we treat the sleep apnea, and people may totally neglect to deal with the other aspects of what's going on with the individual. But the person may still be sleepy during the day, and may still be having fragmented sleep, and may be having dream content. And narcoleptic patients have an increased tendency towards REM sleep because there's poor regulation of REM sleep in narcoleptic patients. So again, once you know that the CPAP has been optimally administered and the person's compliant and they're still having symptoms, it warrants an in-lab study, but they may want to add to that study something called the multiple sleep latency test. So Nicole referred a patient to me from California that I saw first through telemedicine remotely, and then the patient had airway issues and been placed on CPAP and didn't do any good for him. And he's all geared up to do all sorts of surgery and all this other stuff on his airway, and asking, my opinion if I think this is what should be done. But he was excessively sleepy. And when I took his history, I entertained the possibility that he might have narcolepsy. So he came out to Texas. We did a study with nasopharyngeal pressure monitoring, and I was able to identify his very mild degree of obstructive sleep apnea. We did a multiple sleep latency test the next day, and he went into REM sleep on several of the napping studies. And I diagnosed him with narcolepsy. And I said, look, you could do the most extensive treatment in the world on your airway, you're still going to be sleepy. And Nicole, how's he doing now? And tell me what's been done.
Yeah, no, he's doing well, but it's a really interesting case because the orthodontist referred him for MMA surgery, and he clearly has all the craniofacial anomalies that would be consistent with a sleep apnea or an airway disorder: tongue tie, high narrow palate, mouth breathing at night, couldn't breathe through his nose at night. So if you kind of go down that rabbit hole and blind yourself to other possibilities, you can cause a problem for a patient, because if he didn't know he had narcolepsy and got this major double jaw surgery and was still tired, that's a major problem. So after that case, it totally opened my eyes to really reinforcing the fact that I feel every patient needs to have a sleep doctor on their case if there's any signs of a sleep disorder, to investigate other non-airway related causes of the sleep disorder. And you talked about in the last lecture that I believe it's like you felt like 70% of patients with narcolepsy have sleep apnea also. So there's that like co-relationship. So from a myofunctional perspective, I know we need to treat the airway component to restore correct oral rest posture, get it to be a nose breather. I'm not treating sleep apnea, right? Just treating oral rest posture and good functioning. But for this patient, that's not necessarily enough. And a lot of patients, that's not enough. So now the patient is taking medication for the narcolepsy on CPAP, and he's feeling so much better. He's not tired. He doesn't have to nap during the day. I think it was a little difficult to find the right medication combinations or whatever. So that's what Dr. Simmons, obviously that's his role. And so he's doing well. And he's young, like in his late 30s, early 40s, and probably doesn't want to be on CPAP the rest of his life, but I believe he's in a stage of like healing because this has been so stressful. Having this his entire life and going through all different treatments, because he did have some surgeries as well. And it's just like he just is pausing right now to like basically, I think, get sleep and recover and just not do anything else, and just function. Because with the medication, he's not tired during the day. I believe the CPAP is helping him sleep at night. So a lot of our patients have other disorders like narcolepsy that we would never know about had they not been, or if we don't refer them to a sleep doctor to really clearly look at those components. And now I've done so many evaluations that I'm like, I think this person has narcolepsy. I use some of Dr. Simmons' questions that he asked patients. And, obviously I don't mention that to them, but I refer them to Dr. Simmons. And even another patient that we share, I know I read your report, and there's a suspicion of seizures. So it's like another thing we wouldn't know about. Clearly the patient has airway craniofacial anomalies, but there's a suspicion this guy might have seizures, So we just want to not miss these things.
Yeah. Well, thanks for the input. And I guess another common thing would be restless leg syndrome and periodic leg movement to sleep. That's going to coexist with obstructive breathing in a lot of patients. And it's more common than narcolepsy, more common than seizures. Restless legs is very common. And so, again, to Nicole's point, it's important to be aware that there's other things besides airway. I mean, it's great that I'm sure everyone that's online right now is very airway centric, if you will. They're focused on airway, and they realize that it's being missed by other healthcare professionals in the community. And they're like, wow, but just because you have a hammer, everything's not a nail. And so you have to be aware of other sleep disorders.
That's the importance of this interdisciplinary approach. We need to, as different professionals, to come together and have meetings like this. Like I said right before I came on with you guys.
Come to the conference in Houston. We're going to cover insomnia, narcolepsy, restless leg syndrome, and then just a lot of different treatment approaches for these conditions. But yeah, there's a lot of things.
Definitely, it is so important for us to listen to the patient and listen to other professionals, work with other professionals. Ryan said, does this mean that individuals with ADHD and sleep difficulties should also automatically be referred to sleep doctors?
You say automatically. It, I would almost sort of say yes, but so if nothing else, just
Roll out.
exactly. If nothing else, at least to rule out something that is treatable, which may be able to be treated from a non-pharmacologic standpoint. Someone has an airway issue, then the thing to do is to mechanically or somehow anatomically or improve the airway, not to give a medication for the symptoms that are occurring because of the poor sleep as a result of the airway issue. So, and TMJ dysfunction is another common one. A lot of people grinding, clenching their teeth, developing headaches. It could be from an airway problem, a compromised airway, and that's something that I've been talking about for years and educating dentists for years. And now the dentists talk about it like it's common knowledge. It's interesting. But it's, it wasn't so obvious to everybody 15, 20 years ago.
That is so true. Do you work with a rhinomanometry or rhinomanometer?
No.
We had a question about that, if you had experience with it.
I know that people are using that to look at the anatomy of the airway, and they'll do it in patients that are going to be awake. And but it's not something that I have implemented in my practice.
There's a pharyngometer, there's a rhinometer, and there's a rhinomanometer. So I know that they are all different things. And we need people that who do that exactly to be able to explain the differences. But would you guys share what kind of ring that Nicole is using that you're checking over there?
Okay, so
You did a call.
I mean, I'm a little bit reluctant in the sense that it's not so much as the ring; it's how we're monitoring. Yeah, and there's no we're doing something that's out of it's premature. Not really premature. It's not being utilized yet by everybody. And if someone we're doing it's using cardiopulmonary coupling, right? And you can get that. You could do a cardiopulmonary coupling by sleep image makes a ring that does cardiopulmonary coupling. So it's an FDA approved method of assessing sleep, and it was designed for being used for doing a sleep study. First, it was a device on the chest, and then it was using the same analysis. It could be done off of an oximeter that's worn as a ring. The thing is that what I've done is developed a platform with the blessings of Sleep Image. They've opened up their platform for me to develop a way of taking their data nightly and then able to use it for ongoing monitoring. So I can trend the data from a nightly basis, and we've put together other parts of this to where we get other information as well. But Sleep Image doesn't offer that to the public. They offer single nights, or someone could do multiple nights, whatever, of monitoring. If they want to do ongoing nightly monitoring in a medical platform, they can do that through me, through Comprehensive Sleep Medicine Associates. And we do telemedicine visits. And the way we bill it is a different way. We have to bill it as part of our clinical service that we're providing to patients. We're not billing it as a sleep study. So if you contact Sleep Image, you're going to not get the package that I've developed in conjunction with them. So you contact Comprehensive Sleep Medicine Associates, and we can get that into something where we can monitor your patients. And we would then participate in a collaborative fashion in the care of your patients. And that's really what it's about. Now, eventually, this, I mean, well, I don't want to talk too about how things are.
If anybody here is interested in either becoming a patient of Dr. Simmons or having your patients have a consult with Dr. Simmons, I will post on Airway Circle his website and how to get a visit, a consult with him. So you can be anywhere in the United States, I guess, in the world, maybe.
Right. And in some states, I'm going to want the patient to get a primary care doctor involved with us as well. I've got a license in a number of different states, and I'm gaining a license in additional states. But so I want to really also work in conjunction with the physicians in their local states in many instances. But I mean, Nicole sends a fair number of patients to me, and there are a number of other clinicians that do as well.
Well, I do have a question about this that just came in through our Facebook. If this constant monitoring, do you use that for children also? Is there a way?
We are not currently using it for children, but can it be? Yes. And will we ultimately? Possibly, yes. The thing about it is that the utility of this depends a lot on the magnitude of the problem, and even with adults. So, is this something that's good to monitor for patients with upper airway resistance syndrome? I'm not as convinced. Is it good for monitoring patients with clear-cut obstructive sleep apnea? Yes, I'm definitely convinced. So when patients have clear-cut sleep apnea, then I really welcome the opportunity to monitor them nightly. When it's a milder form of obstructive breathing, I think it gets to be a cloudier issue, and a lot of people don't understand this, and they just see numbers and they just say, "Oh, look," and they don't know necessarily what they're looking at. What you're going to get from this kind of analysis is going to be parameters that describe arousal, but not all arousals are from respiratory phenomena. So other kinds of things can cause arousals, and so unless you really know what the patient's condition is, you shouldn't be using the ring to monitor them. So it's good to, in many instances, to have an actual good sleep study that shows the diagnosis on the sleep study, and then you should do the ring test simultaneously with that patient, and that way we can make a correlation, and then we know what parameters we can use on the ring to help us in the management.
Do you have many patients who have had tongue tie releases?
Many, not as many maybe that as could have. I think I probably underutilized tongue tie releases in my practice, and actually I had Tracy Brizendine, who's a myofunctional therapist in Austin, do a in-service for my nurse practitioners on how to evaluate for a posterior tongue tie. You know, anterior is a lot easier to tell, but and so we're trying to get a better sense of that. So I think that we could be utilizing that to a higher degree. But we have patients that have had, and I realized early on that in some patients it was making them worse. But when you look closely at what was going on, they did not have myofunctional therapy implemented, months before they had the release. And so the patients became more vulnerable. And so that's important. So, and you guys know this because it's in your wheelhouse.
Right. And I think that's the key, is that the release is one component to the myofunctional therapy, and it will only make the myofunctional therapy work better, but that's not the solution. So it just helps establish correct oral rest posture with myofunctional therapy. I actually have my patients sign something when we review the referral for the tongue tie release, that they understand that it's the myofunctional therapy that's going to help, and the release is going to help the myofunctional therapy work. So one of the questions was saying, does a tongue tie revision in adults with sleep apnea improve the breathing enough to resolve the sleep apnea? And I would say kind of take the thought away from having a tongue tie release resolving the sleep apnea, but establishing correct oral rest posture can help with better breathing. And if a tongue tie release is required to help the tongue establish correct oral rest posture up on the palate, then yes, that could help resolve the sleep apnea. But I don't know if we have enough information to know if it completely resolves or if it helps the breathing get better. But as a myofunctional therapist, I'm always very careful to let my patients know that I'm not treating snoring. I'm not treating sleep apnea. I am treating the oral rest posture and the chewing and swallowing. And as icing on the cake, those things tend to get better. But if you make your patients think you're treating their sleep apnea or their snoring, then you can find yourself in a really difficult situation in the end. So you just keep your goal as what are your goals in myofunctional therapy.
Definitely. We need a lot of research to try to answer a question like that. It's going to be a long time before we can know for sure, if these things are related. But this has been a wonderful talk. We have reached our time. And just like last time, we went through the first few questions, and it's always wonderful.
So here, I'm going to do this one more time here. I encourage people to come to our conference. Right? So you're going to learn a lot. And a lot of what we covered today will be covered in more detail at this event. And there's just a lot of good stuff with early intervention, orthodontics, and combination therapy with aligners and oral appliances, and some new approaches from a oral surgical standpoint in terms of maxillomandibular osteotomies using 3D printed plates that can be surgically. The surgery time could be now reduced to 2 hours instead of 6. And just a whole bunch of things. We'll talk about the remote patient monitoring and other conditions related to connective tissue disorders overlapping with autonomic dysfunction and mast cell dysfunction. Some new conditions that are being recognized now that they'll be discussed in the lecture. Dr. Maxwell from California is going to be coming out to give a talk. Andrew Maxwell. He's not listed in the name. There's some other. We haven't listed all the faculty on this particular graphic that you see here.
Can I
There's
do
more.
Dr. Simmons?
What's that?
Can I do something?
What's that?
For everybody, let's do non-health professional. If you guys are not part of Airway Circle membership yet, so this is gonna go. I don't know if something turned off. This is gonna go. Are we still?
Oh, I took it off. I stopped sharing. I didn't think.
Oh, okay. That's what happened on my screen. I want to give something away. It's been a while since we're giving stuff away. So Airway Circle is going to pay for a non-dentist health professional to go to this conference. But you have to be an Airway Circle member with a regular Airway Circle membership right now. So if you will sign up. If you're not a member yet, you need to sign up by tomorrow night. I'll pick somebody on Saturday. Can we can already register, right?
Yeah.
Perfect. Okay, so we're gonna pick somebody on Saturday. So if you're not a member yet, sign up right now. It's only $25 a month, and you're gonna get to go see Dr. Simmons and all these amazing people. Okay, we're gonna pick one person. Kimmy, you're always in everything. Kimmy, I see you over there. So you're entered. But I need something to be able to pick people from. So this is what I'm gonna do. I just want to make sure it's fair. I'm going to post the photo that Dr. Simmons just had it over here on the screen. If you can email me that photo, I will post that on Airway Circle. And you guys can comment on it. So I'm going to pick somebody from the comments randomly, but you have to be a member. If you're not a member, you're out. All right. Let's see who's going to win.
Right.
A ticket, non-dentist ticket for a health professional to go to this amazing conference. I'll try to be there since I'm not going to Brazil anymore.
Great.
You have to be a member and you have to comment. As soon as I get the photo, I'm going to post it tonight. You guys have all day tomorrow, the rest of the night and all day tomorrow to comment, whatever, tag somebody on there. Share if you want to. You get an extra point from my heart. And we'll pick somebody.
Would it be, can I ask you a question for the conference? Is it something where we can try to get MDs to attend? Like if we can get ENTs, other, doctors in our area to attend?
Yeah, so we're also, the course is going to provide medical CME credits for physicians in conjunction with the Texas Medical Association. But it's not, the course here is 24 hours of CE credits to the dentist, but only 12 hours to the physicians, because the first day is not for the physicians. The second day and half of the third day are for physicians. So so someone can come along, and clearly the physician can be there, but they're not going to get any continuing medical education credits on that first day or the afternoon on the third day.
They're going to get a lot more than continuing education hours.
Yeah, but pretty much everyone that's on here as part of the medical part, except for Dr. V's. Dr. V's is not part of the, but he's going to talk a lot about various appliances, and but Dr. Yosefian is also going to talk about appliances. But the first day with the hands-on sessions, Dr. V's is going to have that. So that's not on the, that's not for medical CME. But yes, I would encourage for dentists or non-dentists to bring physicians. And I think myofunctional therapists, if they bring a physician or two, that'll be great. They'll really all learn a lot and gain from this.
This is amazing. All righty. As soon as you send me that flyer, you guys run to Airway Circle on Facebook. I'm going to post it on the page, and I'm also going to post it on Instagram. So tag people over there, share whatever you have to do to get people to see it. And I'll pick somebody on Saturday. This has been wonderful. Thank you so much, Dr. Simmons.
Thank you.
For being here. Love you guys. And what is going on with Airway Circle next week, Tuesday and Thursday? Go on our link tree to find out, because I can't remember, but I know that they're amazing people. Anyways, we're going to be posting about them. All right, guys. Thank you so much. Have a wonderful night.
Thank you.